Good afternoon, everybody. My name is Nushin Davarpana, and I'm one of the educators at the Alzheimer's Society of Toronto. This webinar series discusses recent updates in dementia research and highlights dementia research studies that are occurring all across Toronto. So this is our agenda for today. Just a little bit of introduction. So you've already heard a little bit about me, but I'm going to introduce you to Alzheimer's Society in case you are not familiar, as well as to TDRA, which is the short form of Toronto Dementia Research Alliance. Dr. McAndrews is going to talk about Alzheimer's disease, what it is, who's at a higher risk, and also other forms of dementia, and also how Alzheimer's disease is distinguished from other forms of dementia. And there will also be a presentation of the Alleviate 2 research study. And then we'll get to the questions. We'll try to answer your questions to the best of our knowledge. And then at the end, the closing remarks. A little bit about Alzheimer's Society of Toronto, or AST for short. We are an organization that provides information, education, and support to people who are living with dementia and their family and friends, healthcare professionals, as well as the general public within the M postal code. We service all dementias, and the diagnosis is not required to access our programs and services. Our services are offered both in person as well as virtually through Zoom and the ALS Educate e-learning platform. So to learn a little bit more about the full variety of programs and services that we have to offer, I would encourage you to visit our website, which is www.als.to, and take a look at our calendar of events. Now I'd like to take an opportunity to introduce you to the Toronto Dementia Research Alliance, or short for TDRA, which is established in 2012. The TDRA is a collaboration among the University of Toronto and 5 major hospitals, which you can see their logo at the bottom of the slide. Together with its partners, TDRA aims between basic science and clinical research to better understand and treat dementia. So I'd like to take this time to introduce you to Victoria Telford, who's from the TDRA, to guide you through with more details.
Thanks so much, Nushin, and thanks everybody again for coming to join us today. So like it was already mentioned, the Toronto Dementia Research Alliance is involved with research and also clinical care in the Toronto area. But what we really want to point out today, since these presentations really focus on active research studies that are going on through the TDRA right now, is that we have a section on our website that's dedicated to active research studies that are going on in the GTA right now. So all of these studies are focused on neurodegenerative disease, and they're open for participation across our partner sites and across the city. The research studies are listed in plain language so that the descriptions are easy to understand for the general public. And participants have the option to fill out a screening questionnaire so that they can easily be matched to a study if you're not sure what kind of research study you're looking for right now. So there are 2 ways that you can be connected to a research study on our website. So the first is by using existing filter options. So it's things like organizing by study location, whether or not you have a diagnosis of cognitive impairment or age. This will help narrow down research study options based on your preferences. Once you fill out those preferences, you'll get some recommendations for research studies that match your eligibility criteria. If you're interested in a study, you fill out the contact form and your information is sent directly to the research team. Otherwise, like I mentioned, if you're not sure about the kind of research study you're looking for or what options there are, you do have the ability to fill out a screening questionnaire. It takes no more than 2 to 3 minutes, and those questions are sent directly to our team at the TDRA. We take that information and match it to the eligibility criteria of our active research studies within our portal. And we send you some study options directly that match sort of what your answers are in your screening questionnaire. Once you identify a study that you're interested in based on the ones that we send you, we connect you with the research team. So that makes it a little easier for people to find their research studies. So we want to introduce you now to our speaker for today. It's Dr. Mary Pat McAndrews, who is a clinical neuropsychologist and cognitive neuroscientist at the Krembil Brain Institute as part of the University Health Network. Her research focuses on memory networks using functional neuroimaging and EEG/MEG, studies of patients with medial temporal lobe damage, and brain stimulation techniques to understand how these networks are organized and modified by focal damage or therapies. An important focus of this work is the identification of individual difference factors that contribute to vulnerability or resilience to disorders affecting memory that can be leveraged in clinical practice. So thanks again for joining us, and I'll pass it over to you.
Thanks very much for the opportunity to speak with you today. I am going to give a bit of a background on Alzheimer's disease first before I talk a little bit more about the study that we're currently conducting. So let's move on. So Alzheimer's is one of several neurodegenerative diseases. What do we mean by that? It means that parts of the brain are going to degenerate over time. And so on this graphic, you can see that dementia is kind of a general term that describes cognitive problems like problems in memory or reasoning, and essentially problems that lead to functional impairment in daily life, the ability to drive a car or fill out your checkbook, etc. And Alzheimer's is a specific type of neurodegenerative or dementia that accounts for the vast majority, actually, of dementia cases. There are other forms of dementia, however, some that have to do with vascular problems in the brain system, blood-brain system. Another type of problem called Lewy body disease, frontotemporal dementia, Parkinson's. These are all various forms of dementia. And of course, we also want to talk about kind of the stages of dementia. So we think of kind of the stage at which we can see cognitive impairment on very sensitive standardized tests, but that may not yet be having an impact on your functioning in daily life. And we describe that as mild cognitive impairment. And then once the impairment starts to impact functioning, then we can kind of grade the dementia in terms of mild, moderate, or severe stages. So what are the precise clinical and brain changes that are associated with Alzheimer's disease? Probably most people recognize that memory is pretty much the first, what we call memory for everyday life, episodic memory. Where did I put my keys? Oh, did we have that conversation yesterday? Language can also be affected, especially your ability to come up with the names of things. Names of people or places, for example, often is recognized first as a problem. And then there can be problems with spatial orientation, problem solving, and the like. And as I said, as those become more severe, we can actually then see them having an impact in everyday activities of daily living. There can also be some psychiatric symptoms that come along with it, more likely in the later stages, once the dementia stage rather than the MCI stage, but anxiety, depression, and either apathy, the inability to kind of get moving and get doing things, or agitation could be an example as well. So what's happening in the brain while all of this stuff is going on? Well, there's two major culprits in Alzheimer's disease, and hopefully you can see my little cursor here. This is a cartoon of a neuron, the basic cells in the brain that do pretty much the activities of thinking and learning and memory and problem solving. So what happens in Alzheimer's disease is that there's two proteins that actually have normal functions in our brain, but that somehow go awry and start forming aggregates of these proteins in places they shouldn't be. So first is amyloid, which forms what we call plaques. And these plaques exist outside of the neuron, but what happens is that they kind of gum up the communication between one nerve cell and another nerve cell. And the second is what we call tau, and this is a protein that actually helps to form the skeleton of the neuron, but it breaks down and then starts causing what we call occlusions, gumming up the works within the neuron. And once these two are kind of the major characteristic features of Alzheimer's disease. They have downstream effects, however, of causing inflammation and metabolic stress, which may also increase the probability of the brain working the way it's supposed to be working. And if we look at, again, these kind of cartoon pictures at the bottom, we can see the kind of ideal of the healthy brain. This is looking at your brain. This is the top of your head. Here's the bottom of your head. And you can see the nice structure here, and including these structures in what we call the medial temporal lobe. And these are the structures that are first damaged in mild cognitive impairment. And then by the time one is advancing to severe Alzheimer's disease, these structures are pretty much gone, but there's also problems within the rest of the cortex. So basically, these kinds of protein occlusions are going to cause the death of neurons, and that's then going to be picked up on these techniques like CT and MRI scans. So there's actually now a very clear cascade of biomarkers that we think of as defining Alzheimer's disease. And again, this is way before you actually are diagnosed with mild cognitive impairment, which means you're having trouble thinking, or dementia, which means the trouble thinking has actually now caused you to have trouble operating in daily life. So this is the amyloid beta that we talked about. In fact, we can see that it starts rising up. This is from normal to an abnormal signal. It starts rising up about 20 years before we can start to see changes in terms of cognitive thinking. This tau-mediated protein that's aggregating inside the cells comes up a little bit later, but starts rising again. A lot of it risen before we're starting to see the impact in terms of thinking. Then we start to see loss of brain structure, loss of cognitive functioning, and loss of your ability to function in daily life. So these, as I say, especially the amyloid and the tau, are now kind of the quintessential things that we're looking for in terms of being able to see how likely you are to be on a trajectory for Alzheimer's disease. Because again, these are occurring, this aggregation of these proteins is occurring before we're seeing any kind of clinical symptoms at all. So who might be at higher risk of developing Alzheimer's disease? Most cases are related to a number of different factors. We'll go through these in a little bit more detail, but age is certainly the most prevalent factor, family history, genetics. There are some modifiable risk factors that we'll talk through because those are things you can do something about. And then certain medical conditions also may predispose you to having Alzheimer's disease. So let's go through some of these. Age. The risk increases with age. Most people with Alzheimer's are over 65, although there are some that can be affected in younger people as well. Sex. Women are actually twice as likely to have Alzheimer's disease. And it isn't just a function of living longer than men in general. In fact, we do think that there might be some important changes around the time of menopause that might increase your risk or might make you more vulnerable to some of these changes that we've talked about in the brain. And genetics. Although familial genes are very rare, they can cause Alzheimer's disease. And these are actually much more likely to be associated with early onset Alzheimer's disease in your 40s and 50s. Very, very rare. These are presenilin genes, etc. There are other risk factor genes that are common and can increase your risk, but they don't always cause Alzheimer's. And in fact, we're going to go through the one apolipoprotein gene E, or ApoE, which is the one I think most people have heard about in the real world. So let's drill down a little bit about that, because certainly that is one thing that has become very well known in the community. In fact, you may or may not be aware that you can actually even get your genotyping for this particular gene at Life Labs with a doctor's request. So it is something that we know has an increased risk of developing Alzheimer's disease, but it doesn't cause Alzheimer's disease. It actually does affect how this amyloid beta is handled in the brain. So of course you get one copy of this gene from your mom and one copy from your dad. And in fact, if you have the E2 variant, it's actually great. It actually helps you clear out that amyloid, so you have a decreased risk. If you have an E3, you have normal processing, so an average risk. it's if you have this E4 version, and particularly if you have 2 copies of that E4 version, that there's a much higher risk of developing Alzheimer's disease. And again, that's because it interferes with, or it impacts how that important protein that normally gets cleared out of your brain doesn't get a chance to clump up in those spaces between neurons. It helps to clear that out. If you've got the E4, it's not that effective at clearing it out. I like to highlight this because, as I said, you can't control your genes, but you certainly can have control over some of these factors that may add up to increasing your risk. So there are lifestyle factors like depicted here in terms of alcohol use, diet, staying physically active, keeping your brain active, social connected. And there are certain health conditions. Certainly diabetes is becoming, and high blood pressure, cholesterol, obesity. These are becoming very common to be looked at these days. And I will just give a kind of nod to the fact people are even starting to look to see whether or not taking a drug like Ozempic, one of the GLP-1 drugs that actually can help control diabetes and obesity, might actually have some benefits down the road in terms of the development of dementia. So really interesting that way. This is a busy slide. The only thing I want you to take away is that we don't say these just as a kind of nostrum, you should live a good life and everything will go well, but we can actually see how each of these risk factors can have a direct impact on the kind of changes in the brain that we're trying to eliminate or reduce or mitigate in terms of the vascular damage, the changes in amyloid and tau, the stress and inflammation, and building up what we call cognitive reserve, the ability of your brain to resist or to compensate for some of these changes. So they all have very good evidence behind them. In fact, the evidence is so striking that we've had, I think now, 3 reports from the Lancet Commission, which actually takes a survey of all the literature that's out there and tries to say, okay, if we were able to have an impact on these modifiable risk factors in the population at large, how might that reduce the risk or the prevalence of dementia in the community? And you can see what they've done is to group them into certain factors like early life. And we definitely know that there's a less likelihood of developing dementia with individuals who have higher levels of education. There are a number of things in midlife, and you can see a whole host of things here. As I said, cholesterol has been now identified, diabetes, excessive alcohol use, obesity. So these are things we could have an impact on, and having an impact in midlife is probably what's important, because you remember that curve that showed you that amyloid is starting, 20 years before you've actually developed any kind of symptomatology. But even in later life, there may be, the evidence is suggesting that there could be certain things that you might be able to do that would reduce the burden of these factors on brain function. And that includes things like visual loss, air pollution, and particularly social isolation. There's lots of really nice evidence now suggesting that one of the most important factors that can help to preserve brain health later on is this ability to keep active with other people. And interestingly enough, they said we could imagine that 45% of these, of risk of dementia in the community, these represent 45% modifiable risk factors. Okay, so to get taken together. So it's not going to eliminate dementia, but it certainly may have an important impact. And there are a number of different slides I could have presented here. Here's just a cheery little one from the Ontario Brain Institute that basically summarizes these in terms of strategies that you might be able to entertain to help mitigate or reduce those risk factors, like sleep. Brain is very important for sleep. In fact, most of the clearance that happens, taking out those toxins and those nasty aggregates of those proteins, happens actually during our sleep. So not having sleep means that you're actually not giving your brain the best chance to clear out the junk. But also, keeping in good mood in terms of relaxation, not letting stress, because stress elevates certain hormones that might cause stress in the brain. thinking and doing things, making sure you take care of your nutrition, making sure that you stay active in terms of cardiovascular help, and as I said, get social. That really does seem to have a very big impact in terms of keeping brain health at its maximum. Okay, so people might say, okay, you've said what I might be able to modify, but what if we're in the stage where we're worried now? We either have been diagnosed with mild cognitive impairment or early dementia. What are the treatment strategies that might be available to me? And so I just wanted to go over a few with you, and the next couple of slides are all organized, so they talk about what's the strategy, why are we doing it, what are the specific available treatments, and who is it aimed at, right? So the first and the most kind of, exciting breakthroughs over the past decade have been what we call disease-modifying therapies. And the idea here is that you're really trying to look at the underlying pathologies, those little curves that are inching up, and trying to stop them in their tracks, basically. Let's see if we can do something. So the one that's actually been approved, not only in the US but in Canada, is really targeting this amyloid beta protein, those plaques in the brain. And the idea is if we can clear those out, we might actually be able to stop the progression of the disease. And as you see, there are actually two medications, two therapy strategies that have been approved. They're not covered by OHIP in Canada, and so they are currently a bit expensive for individuals to undergo. They're aimed at individuals with early Alzheimer's disease or mild cognitive impairment. But of course, you first have to that has to be confirmed with a PET study that shows you have too much amyloid in the brain, because there's no point in giving you a therapy if that's not your problem, basically. We're going to remove amyloid. We need to make sure you have too much in your brain. And this is pretty intensive therapy. It actually requires you to get infusions of the drug. You have to be monitored very carefully because there are side effects, and in particular, side effect can be bleeding in the brain. So that has to be monitored super carefully. But it, as I say, an exciting breakthrough because the first in quite a number of years that seemed to target this idea of modifying the disease rather than just working with the symptoms, which is basically what this next strategy is about, giving some kind of symptomatic treatment that might boost cognitive functioning, even if it's not taking care of that underlying pathology, which is still marching on. So in particular, one strategy that's been used for decades is to boost this particular neurotransmitter called acetylcholine that we do know is important for memory and learning. And so maybe we'll be able to kind of hold off that decline for a year or so, basically. And you can see the various drugs that have been approved and can be used for that. And again, in this case, they would be given for individuals who are already in a condition of mild to moderate Alzheimer's disease. The last one, memantine, may be used later on because it's a little bit more for some of the more complex kinds of presentations. And again, this is not going to change the course of the disease, but it might actually boost up. Remember, you're losing brain cells that produce acetylcholine and other things. And so the idea is to boost up what's available in the system. Then we can look at what we call other kinds of symptomatic treatments, and these are actually aimed at what we might call behavioral or psychological symptoms. These are things that emerge later in Alzheimer's disease. Mood, behavior, sleep issues to address some of those symptoms like we talked about, agitation, depression, etc. It's really meant to improve the quality of life and reduce distress in individuals who are experiencing these symptoms. And again, there's a whole host of different medications that might be provided, again, with very careful monitoring because, we want to be able to manage symptoms without causing any adverse effects. And the last kind of strategy we can talk about is something that could be used at all stages of Alzheimer's disease, this supportive or non-pharmacological approaches. So making sure that we can do everything in the environment, for example, to be able to enhance people's well-being and independence and quality of life. So things like cognitive stimulation, physical activity, sleep hygiene, all of those kind of modifiable risk factors we talked about that can be useful at any point in time and certainly not just for the individual with the disorder, but also with helping with caregiver and education support so that they can do their best in being able to assist their loved ones. So that's just this chart in a nutshell, but I think it's important to know that these treatments that we've talked about are most effective when they're started early, that not all patients are eligible for these anti-amyloid therapies. Again, you would have to really discuss both, do you have this positive sign on PET that allows you to be enrolled in the trial, or PET or cerebrospinal fluid tap, and then really discussing risks with the family doctor. In fact, the most recent data suggests that if you are an E4 carrier of that ApoE gene, this might not be the therapy that's meant for you, basically. Even though it's associated with an increased risk, it might also be associated with an increased risk of bleeding from the brain, which is, not a good trade-off there. And all of these will really require regular follow-up and individualized care. So any of the therapies that we have available to us now, except for the supportive ones, it's really important to be, clued in and hooked in very well with a great family physician or behavioral or cognitive or behavioral neurologist to help with that. So hopefully that gives you a little bit of an insight into kind of the general background from beginning to end of the Alzheimer's journey. Now I want to talk about this particular study that I'm conducting in collaboration with some scientists and clinicians at Sunnybrook. Dr. Sandra Black, who's a behavioral neurologist, cognitive neurologist there, who's done Alzheimer's work, dementia work for decades, as well as Dr. Krista Langto, who is a pharmacology specialist. So we wanted to ask the question, if we were able to kind of spot things early, can we do something about it? Let me just go into the bit of a background with this to say, this slide now, I've shown it to you before. But now what I want to introduce is a relatively new concept of maybe something else that might be happening that might actually accelerate the transition from this stage of A beta to this stage of tau. Because obviously there's some period of time where it's not that nothing is happening, but there might be some things that are happening, and we're trying to think, can we target something that might be happening? So what we decided to look at was this idea of activity in that part of the brain I showed you on those cartoon slides that is affected early on in the course of the disease, the hippocampus. So I'll show you a little bit more about that, but there's some decent evidence from both human studies and from what we call preclinical or studies with rodents. Normal activity might actually accelerate or become hyperactive in this hippocampal region even before you start seeing major impacts on this rise in tau, and then it actually diminishes as you run through the MCI and dementia stages. So there may be some kind of tipping point in terms of what's going from normal activity to too high activity that might actually accelerate or produce more pathological damage. And so why is hyperexcitability a problem? I mean, that seems like a reasonable thing to do. So a lot of this we actually know from another field that I work a lot in, which is epilepsy, which you might think of people having seizures. The seizures that occur especially in this area of the hippocampus, but elsewhere in the brain, we might think of as too much excitability in that region. That's why you need to tamp it down with medications that will lower that. And so we can think of the normal brain as having a kind of reasonable balance between the amount of, in any part of the tissue, excitability or excitation, how easily the neurons start to fire and communicate, and inhibition, that is, how much other neurons or other brain regions might dampen down that input. And actually there's just some neurotransmitters that are mostly associated with this excitation versus this inhibition. And so in the normal brain, there's a balance between these two, basically. And what we know from many, many decades of research is that there's actually this terrible imbalance in the epileptic brain, where the seizures are starting from, where you get way too much excitation and reduced inhibition. And in fact, we think it's this reduced inhibition that's failing. They're losing some of those cells that actually help to kind of keep things in good rein. And I don't want you to try and figure out all of this cascade, but this is really just to try and show you again that there's very good scientific both evidence and rationale for how you get from a hyperexcitable hippocampus into these chains of events that are happening that cause the amyloid in conjunction with the tau to start causing more stress on those neurons, to cause the tau to spread and to cause the killing off of neurons that then cause all of these impairments. And so our question was, well, what if we can stop it at that stage? What if we can actually reduce this hyperexcitability? Wouldn't we be able then to have a disease-modifying therapy that could stop the chain of progression that leads to that dementia? So again, I'll just kind of remind you, this hippocampus, this area that we see here in green, that's kind of slicing your brain down the middle, is very important. It's critical for memory, and it's early damage by Alzheimer's pathology. Again, I've shown you some MRI pictures here. Here's a healthy hippocampus out on each side of the brain outlined in green. And here is a scan from an individual with mild cognitive impairment. And I think you can appreciate that this nice, healthy, chunky tissue is actually reduced here. You're losing a lot of the signal of the neurons in there. So we know that there is some evidence of this hyperactivity that's been linked to Alzheimer's disease. So way back in 2005, there was a study that came out to show that when an individual was in an MRI scanner doing a memory test, we could measure the amount of activity in this hippocampus, and you can see that as you go from a control, a healthy individual with no Alzheimer's disease, to MCI and to AD, there's a change in the amount of activity that we can see. You actually get this exaggerated hyperactivity in the MCI, and then it falls way down below normal in Alzheimer's disease, just like that curve I showed you suggested. And you might say, well, okay, we've known this for 20 years. What have you guys been doing? Sitting around and doing nothing about this hyperactivity. It's not been exactly nothing. Initially, people actually thought, well, maybe it's just working harder, okay? So that makes sense. It's working really hard. And then by the time you've reached the Alzheimer's stage, you can't actually, there's nothing there to work. So it makes sense, right? Working harder to get the same outcome. But in fact, much of the additional studies that took place over the next few years suggested that this actually might be this imbalance of activity. And so there might be actually seizure-like activity happening in the hippocampus in association with mild cognitive impairment for Alzheimer's disease. And a number of different studies came out, these all led by a group in the at Johns Hopkins that kind of showed, first of all, that there was this hyperactivity and that you could reduce this hyperactivity with a particular drug. A drug that's actually used in seizures in epilepsy. And they were able to show that in a couple of different cohorts. And then they tried a study to see whether or not using this amount of drug could actually slow the progression of Alzheimer's disease in patients with mild cognitive impairment. And actually this trial unfortunately did not show that slowing. They didn't show a significant effect. And our question was, are they starting too late? In fact, if you're there, then maybe you're actually already past the point at which you can do something really useful. So our first phase of this study was to say, well, what's normal activity in healthy individuals? Because if we're going to enroll people to give them a drug, we just like in the amyloid case, we should know that you're hyperactive before we give you something to reduce the activity. And so, just as a kind of cartoon version, we know that the hippocampus, when it's seeing something for the first time, gets very innervated. The neurons start firing so that they can lay down new memory traces. And if you see something over and over again, it's basically less excited. So we took advantage of that idea. And we can see that in using fMRI, and we could divine what is a normal level of activity here. So we can say, okay, we took 40 individuals. We said, okay, this is the distribution of activity that we're seeing, and then we can say, let's set a cut point and say who we should enroll. And just to say that we're also using, besides fMRI, which other people have used, we're using a completely different technique called MEG that actually allows you to look at the neurons a bit more directly. So to see whether or not we can get a signature of this overactivity there. The key technologies that we look, again, MRI on the left, just so if you were a person in the study, you would know you kind of go into one big tube and then you go into a smaller tube, basically. And these are our ways of actually recording brain activity while people are doing these memory tasks for us. And now we're in phase 2. We understand what the normal levels of these activities are. And now what we're trying to do is to say, enroll people who might show this hyperactivation and give them this small dose of this drug called levetiracetam that can show, can normalize activity. This drug is known by the name Keppra. And in much higher doses, it's used in people with seizures. So we know it actually directly impacts this excitation-inhibition imbalance that we're trying to target. And who is eligible to come into our study? It's individuals who fit these following criteria. They are in a particular age range, 55 to 85. They have concerns about their memory, so they have, and they have a parent or sibling who had dementia. Or if we have already biomarkers for these individuals from PET, or they have genetic risk as positivity, they can come in even if they don't have memory concerns. And at the moment, they're screened to be normal in terms of their cognitive function. So again, we're trying to look earlier in the stage before you can be diagnosed with a condition like mild cognitive impairment. And the initial screening actually can take place virtually, or we also have teams at both Sunnybrook and Toronto Western who are able to do the screening. What does the study involve? You get cognitive testing and questionnaires. We do blood draws for genetic testing. We do brain imaging, the 2 types I told you about at the Toronto Western. And then if you're enrolled in the study, you get this medication for 4 weeks. And we do what's called a crossover trial. So we compare in each individual what their brain is like when they're on the drug versus what their brain is like when they're on placebo for 4 weeks. We don't know, you don't know whether you're on the drug or just a capsule with nothing in it. And we want to be able to see for an individual, does this drug make a difference rather than, for groups of people. I've been asked before, what are the side effects of this medication? Again, it's used primarily in people with epilepsy, and it's used often as a secondary medication, so it's often on top of other medications, and it's used at 4 times the dosage. We're study that didn't show a positive effect, but out of the 78 patients, you can see that 1 or 2 individuals had experienced one of these complications that they were able to report. So we don't anticipate any significant adverse events. I'm going to skip over the next slide, but just to tell you, this is basically what it looks like. So there's visits in order to determine eligibility, and that means do you fit our criteria? And do you show this hyperactivation in the MRI, in which case then you'll be enrolled, as I said, for a treatment phase of about 4 weeks. Then we're going to wash out the drug, wait 4 weeks, and then the other treatment phase. And either you'll be randomly assigned to the first condition where you get the drug and then placebo, or a situation in which you get placebo and then the drug. And at some point during this, we actually have a PET scan visit so that we can measure the amount of amyloid in the brain. And I'll skip that one because that's a little bit busier or noisier, and I've basically told you the most important pieces, but I can reveal or talk about some of the others in question period. And this is also because in response to some people's questions about, okay, well, what happens? You said you've taken a ton of different measurements about me, and most of these are new things, and I might or might not like to learn the results of those. So participants are given the option to learn the results of their ApoE status, that potential genetic risk factor. Their amyloid PET, are you a person who has above the cutoff point in terms of what's been determined to say that you're kind of on the trajectory, and their blood biomarker test. So it's entirely up to you as an individual, and you can actually change your decision at any point in time. If results are negative, by negative we mean everything's fine, nothing seems out of the ordinary, then the research coordinator would be able to tell you that. But anything that's a positive result that you might have more questions about, that's actually going to be revealed by a medical qualified investigator, just because you might have some questions that you want to ask, and the research coordinator won't be prepared to answer those questions, so we want to make sure that you've got a physician who's capable of answering those. And then again, just to let you know that this is what we call a Health Canada regulated trial, because we are using a very standard drug in a very low dose, but it's what we might call off-label or repurposed. So this is a drug that's used in epilepsy, but it's not used in individuals who are cognitively normal, who may have some concerns about their memory. So obviously the government wants to make sure that they're on top of things, and so they have seen our protocol and reviewed every smidgen of it. And then last, just to let you know that this trial is actually funded generously by the Weston Family Foundation, who has given us the opportunity to address this question, which I will say we are hoping, obviously hoping to have a positive result so that we can say, okay, if we can identify you as somebody who has this hyperactivity, and if this drug can actually normalize hyperactivity, maybe those are the people we should be enrolling in long-term trials, and not just somebody who's got mild cognitive impairment, because they might actually be past the point in time where we can actually have a positive effect. But in addition, we will be learning a ton about all of these other things. In fact, as I highlighted the idea about using the MEG, it's very exciting because that really hasn't been used very much. So it's a whole different window on looking at this issue of hyperexcitability, and we're agnostic as to whether it might actually be even better than the fMRI that we're currently using. So we're very fortunate to be able to have expertise in both of those domains so that we can really, I think, finally get an answer to this question as to whether or not this is a prudent therapeutic strategy. So I'm going to stop sharing my screen. Thank you very much for your attention, and more than happy to take any questions.